Hello, everyone, and welcome to today's webinar, Pancreatic Cancer Demystified. My name is Dr. Camille Pope, and I am the Chief Medical Lead at Now Included, powered by Acclinate, where our mission is to empower communities to take actions for better health. And today, what we want to talk about is all things pancreatic cancer, so that you all, our community members, can understand the signs and symptoms to look for, to understand some of the disparities that exist when it comes to pancreatic cancer diagnosis and treatment, and also what resources are out there for you as a patient, as a caregiver, or a community member, or healthcare provider who is just interested in learning more, what resources are available to you. This webinar is being brought to you by, again, Now Included, powered by Acclinate, in collaboration with our amazing partners, the Pancreatic Cancer Action Network, also known as PanCAN. And so I will be moderating, but we have some amazing panelists joining us today. And so I would like to go ahead and allow them to introduce themselves, and then we'll just jump right in with having our discussion. So first, we have Dr. Colin Weeks.
Hello, everyone. I'm Colin Weeks. I'm a medical oncologist, and I lead the pancreas cancer program at Massachusetts General Hospital in Boston. I've been taking care of patients with pancreas cancer for the majority of my career, and have focused on developing new therapies for pancreas cancer. It's really wonderful to be with you today.
Wonderful. Thanks for being with us, Dr. Weeks. And then next we have Ms. Fatima Zalata Arenas.
Hi, everyone. Thank you so much for having me. My name is Fatima, and I'm the Senior Director of our Patient Services Program over at PanCAN. And I've been with PanCAN for almost 15 years, working closely with patients and caregivers and others impacted by pancreatic cancer, and love the work that we do. So I'm so happy to be here today.
Nice to have you. Thank you so much, Fatima. And then last but certainly not least, we have Ms. Pamela Jackson.
Hi, good morning, everyone, or good afternoon. Pamela Jackson. I am a 13-year thriver. I'm also the Chief Compliance Officer for Mission Healthcare, Home Health, and Hospice.
Awesome. Thank you for joining us, Pamela. So let's get started talking about signs and symptoms of pancreatic cancer. So, Dr. Weeks, pancreatic cancer is often called like a silent killer because the signs and symptoms can be pretty vague, and we know that it's often not diagnosed until it's in the late stages. So can you talk a bit about some of the signs and symptoms that patients not a patient to diagnose, but signs and symptoms that we might want to look out for that might indicate that pancreatic cancer may be an issue? What are some of the things that we should know about?
Yeah, so I would say, first of all, is that pancreas cancer most commonly occurs in patients in their 60s and 70s historically, although one of the trends that we're seeing currently is that it's occurring in younger patients more commonly. And so when I say younger patients, now I'm talking patients in their 50s more commonly. It's a genetic disease that occurs sort of over time. The symptoms that patients generally experience can be anywhere from unabating abdominal pain, and usually it's in the upper abdomen, kind of across the middle of the upper abdomen. Patients can also have back pain as well. And that back pain is usually the upper back, kind of between the scapula, and that's due to where the pancreas sits in the body. And then patients can also experience profound fatigue, night sweats. In terms of eating, they can lose the desire to eat or become full earlier than they normally would when they eat a meal. That ultimately can result in weight loss, sort of for untold reasons. And patients can also experience fevers, night sweats as well. And then so there's two things that sort of can happen with pancreas cancer that patients can also experience. So because one of the roles of the pancreas is to regulate your blood sugar, patients who have diabetes and have had a historically well-controlled diabetes commonly may have lack of control of their diabetes sort of prior to being diagnosed with pancreas cancer. And it's also common that patients who don't have diabetes develop glucose intolerance, so they have high blood sugar levels prior to being diagnosed with pancreas cancer. Another role of the pancreas is to regulate how you digest your food. And so some patients can also experience abdominal pain and bloating after they eat, as well as frequent loose stools after they eat as well. And that's due to the lack of enzymes that the pancreas produces when you digest your food. And then I would say the third sort of symptom that's once again an associated problem is that patients with pancreas cancer have a high propensity to develop blood clots. And so sometimes patients can develop swelling in one or both of their legs. And then when we evaluate that swelling, we'll see that there's a blood clot. And then we look a little bit further and we'll see that they may have pancreas cancer. They can also have these same blood clots in their lungs. So they could present with shortness of breath, coughing, fevers associated with that as well.
Thank you. Are any of those symptoms more common, at earlier stage disease, or are all of those more common in later stage pancreatic cancer? Like, what are some early signs that people can look out for so maybe they're able to catch it or get checked out before it gets too advanced?
Yeah, I think those symptoms all happen throughout the disease. One thing I failed to say is that sometimes patients will just turn yellow. They'll notice that the whites of their eyes are yellow. Their skin may itch, their urine may turn very dark brown. Classically, it's described as being tea-colored urine, and that's because of the tumor is blocking the bile duct system, which drains the liver. So the symptoms that patients experience with pancreas cancer have to do with, so for example, if the tumor is blocking the bile duct system, that can be an early sign of pancreas cancer, but it can also be a very late sign of pancreas cancer. So these signs and symptoms, unfortunately, are not associated with any sort of stage of the disease, and which is why, unfortunately, most patients do present with advanced disease at diagnosis.
I see. Thank you. Well, Pamela, as our patient thriver on the panel, can you tell us a bit about your experience when you were diagnosed? Were there signs and symptoms that you noticed, and what was it like as you found out that you had pancreatic cancer?
Yes, Camille. So my story is kind of interesting. I was actually pregnant. I was in my third trimester. And my initial symptoms were I had a radiating pain going across my stomach. So my husband and I thought I was going into labor. I went to the hospital and they started checking me, and then I threw up bile. And they said, no, this isn't labor. There's something else going on. They ran tests. My lipase and amylase were elevated. And so when that happens, the way they treat that is you go into the hospital for several days and you receive IV fluids. So I received IV fluids that time, maybe 3 or 4 days. During that last trimester, I was admitted to the hospital an additional 6 times with pancreatitis, and same thing. So I was on IV fluids each time 3 or 4 days. Once I had the baby, I had an endoscopic ultrasound, and that endoscopic ultrasound did not show anything. And at the time, Norco was freely given. So I had maybe 30, 60, 90-day supply of Norco. I would have pain that radiated across my stomach at times. So I would, take a Norco because the test didn't show anything. I was in Florida traveling for business, and I went to Disney World. And at Disney World, I, popped a Norco and did the little excursion that I had signed up for. But I was in so much pain. I told my husband, I'm going to come home early because I'm in a lot of pain. And he said, no, I want you to go to the hospital there in Florida. So I went, and they ran tests, and they thought it was pseudocyst. And it turned out to be acinar carcinoma. But the saving grace for me, I think, is the tumor was positioned where my bile, the flap couldn't open. And so that's where my excruciating pain was coming from. So fortunately, they were able to identify that, and from there, I had the tumor removed.
Wow, thank you for sharing your story. So it sounds like there were a couple of misdiagnoses before, the physicians finally figured out what was going on. But then also, the fact that you were pregnant kind of complicated things because you didn't know if, am I pregnant, or is it, is it going into labor, or is it something else? And then you also mentioned a specific type of pancreatic cancer. So I'd love to hear from, anyone on the panel who would maybe like to talk about the different types of pancreatic cancer, and, maybe the differences in signs or symptoms, or even, the ability to treat those different types of pancreatic cancer.
Yeah, I can address that, I think. So one, I would say it's very common for patients to be having symptoms, get treated for those symptoms, and the symptoms not get better, right? So that is a very common scenario, because at the end of the day, when you think about sort of the way medicine is practiced, right? So medicine is practiced based upon the odds of a specific disease given a constellation of symptoms, right? And so pancreas cancer would not be on the top of your list for a lot of the symptoms that patients experience associated with pancreas cancer. Given, particularly in a young woman in her 30s, that wouldn't even really be on the radar for a patient of that age. Anyway, so the different types of pancreas cancer. So the most common type of pancreas cancer is adenocarcinoma of the pancreas. That's like, when we think about pancreas cancer, that's really what we're talking about for the most part. I would say the second most common type of pancreas cancer is what are called neuroendocrine tumors of the pancreas. And then acinar cell carcinoma is a sort of a uncommon type of pancreas cancer. And there are some other less common types as well. The difference in treatment of pancreas cancer is really sort of, I would say, is neuroendocrine tumors versus the rest. So neuroendocrine tumors are treated very differently than the other types of pancreas cancer. And then it's interesting that we're talking about a patient with acinar cell carcinoma. So those cancers tend to actually do better than, say, the traditional adenocarcinoma. Ms. Jackson mentioned that she had an elevated lipase. So that is for acinar cell carcinomas, that's actually the blood marker that we can follow for patients. Versus for adenocarcinoma, we commonly follow a blood marker called CA19-9. And the treatment for adenocarcinoma or acinar cell carcinomas or other sort of types of pancreas cancer in general involve systemic chemotherapy, traditional cytotoxic chemotherapy, whereas for neuroendocrine tumors, those are treated more with sort of biologic modifying agents. The ultimate treatment for the disease will be dependent upon whether the cancer is localized to the pancreas or not, whether or not it's resectable, or has it spread to other parts of the body, the liver probably being the most common, in which case things like surgery and radiation would not be appropriate.
Got it. Thank you for giving that breakdown. So what I'm hearing is that it's important for patients to understand the type of pancreatic cancer that they have, because there are a few different types and treatment might be dictated based on that type, but then also how far along is your pancreatic cancer? Is it still on your pancreas, or has it spread to other areas of your body, meaning that it's like metastatic? And that could also dictate the type of treatment and care that you get. I'd love to jump to our next topic, which is disparities in diagnosis and outcomes. So we talked about the different signs and symptoms, but I would love to hear from Fatima or Dr. Weeks about like the disparities that exist when it comes to pancreatic cancer being diagnosed. We know that Black patients are often diagnosed later and may have worse outcomes. So what are some of the things that contribute to these differences in different communities and underrepresented communities when it comes to the timing of diagnosis and also the treatments that are available and the outcomes that we might see?
I can start, and then if you want to jump in, Dr. Weeks. So there's a lot of factors that go into this and that are related to outcomes in the Black community, and then also an increased incidence of pancreatic cancer. Some of this is still information that's unknown, but we do know from research that, various environmental, lifestyle, socioeconomic factors can contribute to these disparities. Other factors include various social determinants of health. So these are things that are specific to an individual's environment, where they live, education status, physical environments, things like employment as well, access to healthcare and health insurance, and also social support systems. I think one thing that's really critical is that we need to work on ensuring that patients have access to quality healthcare, but also that they understand symptoms and risk factors related to pancreatic cancer. And then after diagnosis, I think it's really important for patients to understand all of their treatment options so that they can make truly informed treatment decisions about their care. I think that's really critical for patients to know what their options are, and that may include clinical trials, which we're going to talk about a little bit later, but all of the possible options that they may have so that they can really feel informed in making decisions about their care.
Thank you. And I know we'll talk a bit later about some of those resources that PanCAN is actually able to provide to patients. Would anyone else like to talk about, their thoughts on what contributes to some of these differences and how we can address them?
Yeah, I think so. All the factors that were outlined by Fatima are important. I think so there's an interaction between the environment and biology and genetics. And so what we know is that things that cause stress cause inflammation or sort of activation of the immune system. And in part of inflammation, you get this sort of heightened repair process within the body. And so what that means then is that cells are proliferating or growing at a higher rate. So how one develops cancer, it's a function of having a genetic abnormality that normally is cleared by our immune system. But if that genetic abnormality gets propagated into daughter cells or subsequent cells, that's how you develop cancer. And so in the setting of inflammation, the cells are sort of turning over or replicating very, very frequently. And as a result, the body can't stop the process and take out the abnormal cells. And so that increases the risk for someone developing cancer, right? And so in patients who are of lower socioeconomic status, it has been shown that patients who self-identify as Black have a higher propensity to develop cancer based upon the interaction of some of these inflammatory processes with the genetics that lead to cancer. So it is an interaction between sort of the environment that we're in and then the genetics of sort of cancer. And then there's also patients who have a familial risk of cancer, meaning that they have they're born with abnormalities in genes that, in general, those genes function to stop the cells from growing to allow for editing or repair of DNA damage. And those are called tumor suppressor genes. And so if you're born with one of these genes, so the most common one that we talk about in the general public is BRCA, which is the breast cancer related gene. It turns out that those BRCA genes are also important for development of pancreas cancer. So in the cancers that someone's at risk of, if you have a BRCA mutation, pancreas cancer is one of those risks, in addition to breast cancer and ovarian cancer. And so, so there's that component of it as well. And so as it turns out today, all patients who are diagnosed with pancreas cancer are supposed to undergo genetic testing to look for familial risk of pancreas cancer. And that is called germline testing. We'll talk about somatic testing, I think, in a little bit. But so it's really interaction between, say, your environment and how that impacts biology. And then, you know, certain sort of, you know, societies or members of societies in our country, you know, we tend to suppress symptoms that we're having, not tell people that we're having these symptoms, not go to the doctor, right? So all those things are important, right? So I think now this is more of a sort of a population or a societal sort of education that we need to do, which is what, you know, which is great that we're doing this today, but that's really going to be important. The thing about pancreas cancer is that pancreas cancer is going to be the #2 killer of individuals in the United States by 2030. So it's projected to be the #2 killer. And so it's really important for all of our communities to really understand what pancreas cancer is, really be really knowledgeable about, as we're talking about, the symptoms, and really getting patients to see their doctors, you know, more frequently if symptoms do arise.
Thank you.
Hi, Dr. Pope, can I just add, just from a different perspective? I'd have to say that I don't really fit the normal description of who you would consider to have pancreatic cancer. I have a master's degree in health administration, but I have to tell you, when I was diagnosed with pancreatic cancer, I really had no idea what it was. I've done outreach, you know, in the African American community, at the large mega churches about strokes and different disease states, but pancreatic cancer was not one that we focused on. So I had no idea, and I think that a lot of people do not understand what it is. They don't know where the pancreas is, the function, or what to look for. And so in compliance, we have it's a saying that says, you see something, say something, right? So it really translates to, if you feel something, say something, and don't stop until someone addresses it, would be very important.
I love that. Thank you. So I heard a lot of things discussed here. The number one being that there are different factors that can impact disparities. So there can be environmental factors, societal factors, stress, and there may actually be ways that, you know, if we can manage those things to, you know, decrease our risk of developing not just pancreatic cancer, but other types of cancer too. But then also sometimes there's familial risk. So it's important to know, you know, what your genetic risk is. And we'll talk a bit about that in our next section, like genetic testing. But then from Ms. Jackson, thank you for letting us know that sometimes, like, you know how you say people don't look like what they've been through, or they don't look like what they may go through at some point. And you can be, you know, very literate in other areas in terms of your work and your career and your background, but not necessarily know about certain health issues that could impact you. And it's important for us to understand those things as well, so that we know what to look out for, even if we don't necessarily fit, I guess, the societal definition of what a potential pancreatic cancer patient might look like a young Black woman who's pregnant, right? And is having this abdominal pain. So and that's why we have these discussions like this, these panels, where we're inviting any and everybody to kind of hear these different stories and these different perspectives, so that they can have that top of mind should they or someone they know or love experience something similar. So I think this is a great segue into talking about genetic testing. And Dr. Weech talked a bit about it earlier. I will say in my previous life, I actually was, I worked at a pharmaceutical company as the medical director in the pancreatic cancer space. And the drug that I worked on required, or the drug that I was the medical lead for, in order for patients to use it and to work as effectively as it could and should, they had to have a BRCA2 mutation. And so became very familiar with the role that, BRCA and other genes can play, or gene alterations and differences in gene patterns can play when it comes to developing cancer, especially from like a family history standpoint. And I love that you brought up how, we hear about BRCA a lot, BRCA1, BRCA2, and people automatically think, oh, breast cancer, ovarian cancer. But having alterations in like your BRCA gene can, increase your risk for prostate cancer, pancreatic cancer, and potentially other cancers. And a lot of folks don't know that. So, if we could hear from our panelists about the different types of genetic testing, like what does that entail? And then, let's hear about that.
Yeah, I guess I'll start. So there's really two types of genetic testing that we do with respect to cancer. So there's what's called germline mutation analysis, which is what we're talking about now with the BRCA gene. So these are what I talked about before with familial cancers. So that is what mutations that you were born with, and those are passed down by your parents. And so in general, if you're thinking about familial pancreas cancer or familial cancer in generally what we'll see is that there's a pattern of one side of the family, either the mother's side or the father's side of a given patient, where you see a series of cancers occurring in that side of the family. And that then sort of says, okay, well, maybe there is potential for a germline mutation. The other type of mutation that we look at these days for treating patients with cancer are what are called somatic mutations. So the word soma means body. And so somatic mutations are mutations that you acquire as you live your life. And so as it turns out, all of us who are living our lives have some degree of somatic mutation in our body. And normally our immune system will surveil abnormal cells and clear a lot of those cells. But on occasion, it doesn't clear those cells, and you then are at risk for developing cancer. In the case of germline mutations, there's two copies of a given gene, which means, so if you're born with a germline mutation, that means that you've lost one copy of the function of one loss of the copy of the gene. And in that setting, you need to lose sort of the function of both genes when we're talking about tumor suppressor genes. But it's very easy to lose. Now, the odds of losing the function of the second gene is quite high when you're born with loss of the first gene. So I'm going to address Candace Turner's question as I'm talking here now too. And so with respects to BRCA1 and BRCA2 mutations, so historically we thought about those mutations being present in the Jewish patient population, but they actually do occur in patients of African descent. It does potentially impact treatment of patients. So it has been shown that this class of drugs called PARP inhibitors, which is what I believe Dr. Pope was referring to, are now approved for what we call maintenance therapy in patients with BRCA mutant pancreas cancer. And there are some other genes that are in this pathway that involve the BRCA gene that are also commonly mutated in patients with pancreas cancer as well. So really the use of germline mutation analysis is really right now to assess the risk of patients developing family members of a patient developing cancer. Also, in general, patients who have germline mutations, those patients tend to present at younger age with pancreas cancer. And most of this information I'm talking about is going to be relevant to adenocarcinoma. That's by far the most common form of pancreas cancer, and that's where most of the data exist. Unfortunately, acinar cell carcinoma is relatively rare, and so there's not a lot of data specifically to acinar cell carcinoma. And then somatic mutations. So those are mutations that you acquire as you live your life. In the case of pancreas cancer, the most common somatic mutation that we see is a mutation in a gene called KRAS. There's a number of different mutations that a patient can have. It's mutated in approximately 90+% of patients with pancreas cancer. The sort of the unique thing today is that there's now a number of drugs in development that are targeting KRAS directly, either targeting the fact that you have a mutation in KRAS, and then there are also drugs that are targeting specific mutations that occur in the KRAS gene. So today we are now using these somatic mutations as potential biomarkers of the disease, but also potential ways to think about therapy for patients. And as we learn more about these drugs, these drugs are currently in early phase clinical investigation, so what we call phase 1 investigation, which we're sort of looking at safety, toxicity, dose finding. So they're only available to patients in that setting. So in terms of when we talk about clinical trial participation, by participating in clinical trials, you then get access to these novel drugs that may benefit patients. And so really that's how we're utilizing these sort of different types of mutations that exist today for therapy for patients. And that applies across cancers, but definitely is something that applies to pancreas cancer.
Thank you, Dr. Weeks. So then one last question around genetic testing for Pamela. So because you have the rare type of pancreatic cancer, I'm assuming you didn't get genetic testing, but maybe you have had it. Have you? And if not, would you consider it? And if so, what was the experience like?
Definitely. So at the time, I did not have any genetic testing, and I have not had any. But I do have children, and I am interested in having genetic testing for my family. I would most definitely welcome the opportunity to participate in genetic testing myself, as well as my children.
Thank you for sharing.
If I can just add one piece to that.
Sure.
So if we're doing sort of genetic testing, and what we would apply to Pamela would be the germline mutation analysis, right, to see if her family's at risk. So the way that we would approach that is we want to test the patient who has the disease, right, to see if that patient has a specific mutation. And then if you were going to test, say, her children or members of her family, we'd be looking for that specific mutation in those individuals, right? So it's really important to start with the patient first. And then I think the other part of this conversation, which may be a little bit much to get into now, but is what is the consequence of having a positive test, right? So, for example, if you have a positive BRCA mutation as a young teenage girl or boy, right, that has implications for, what do you do? Do you do sort of prophylactic mastectomies, prophylactic oophorectomies, which means removal of the breast, removal of the ovaries? Do you do medical suppression of ovarian function? So all those things sort of come into play. And so it's really important to do this germline testing with genetic counselors who can help you navigate the consequence of a positive test as well as the consequence of a negative test. And what we're finding is that a negative test does not necessarily mean that you don't have an abnormality. So as technology improves and our capacity to look to find the rarer genetic mutations, like if you tested someone today versus that same person being tested 10 years ago, they may have had a negative test 10 years ago, but today they would have a positive test. So it really is important to do these genetic testing that we're talking about, germline testing, in a very sort of controlled manner. It's in many cases, it's simply just a blood draw, or they can like get some DNA swab right from your mouth. So it's very easy to do, but you do want to have the appropriate support to help guide you with the results of that test.
Thank you. I think that's great context there. So what I'm hearing is you want to start with the patient first, but then also ensure that there are genetic counselors and other providers who can help guide and have those discussions based on whatever those results might be. But it is certainly something to consider as a patient. So,
can I just add one more thing? Dr. Weeks, I want to thank you. I've learned more today than I have ever. I really feel enlightened, but I definitely would be interested in testing for myself because I carry stress internally. You would never know the amount of anxiety or stress that I'm feeling if you're looking at me. But on the inside, there's like a turmoil, there's just a storm brewing and you don't know it. I don't scream, I don't, so I would be very interested in testing for myself.
So I think, Pam, we're not that much different in terms of how we manage stress. And I think that is, a common theme amongst people of color, right? They have to function in the world. They do have sort of unique stresses, and we don't always manage stress that well. And so that's why I think, in going back to the question about this disparities and sort of Black folks and so forth, is that stress does impact your biology on multiple levels, cancer being one of those, but it has other implications too. And so absolutely, and I'm glad I can be informative for folks on the call.
Thank you all. This is great. Thank you for sharing, Pamela. Thank you, Dr. Weeks and Fatima, for being so knowledgeable and being able to inform all of the attendees. And, again, I'm hearing so much in terms of just like the support that is needed, really just in life. I mean, sure, when you're diagnosed with an illness, but even just managing those things to help prevent stress or help you better manage your stress, because that'll ultimately help with preventing disease later on in some instances. I'd love for us to now transition to our next topic, which Dr. Weeks, you talked a bit about, and that's clinical trials. And so, Fatima, we can start with you. What's the importance of clinical trial participation when someone has been diagnosed with cancer, or at least considering clinical trials? And how would one go about maybe finding an opportunity? And what are some common misconceptions that may keep people from participating if they do have an opportunity offered to them?
Happy to answer that question. So there's, one of the most important things that we oftentimes talk about through our patient services program is just that patients should be aware of all of their treatment options, and that includes clinical trials. And some of the common misconceptions are more around, not getting good care if you're on a clinical trial. A lot of patients are afraid that they're going to be experimented on or that they're going to be guinea pigs. That's something that we hear a lot. So oftentimes clinical trials can provide actual access to better treatment options and also give patients access to cutting edge treatments sometimes. So like Dr. Weeks mentioned earlier, there's a lot of things that are, a lot of therapies that are being investigated right now, and many of them are available only through clinical trials. And the other piece that's really important about clinical trials is that clinical trials are really the only way that we're going to continue to make progress in pancreatic cancer, in treatment options, even in diagnostic tests and everything that, is around pancreatic cancer, its treatment, diagnosis. we are only able to make progress through clinical trials, because every therapy that's approved today has gone through the clinical trials process in order for it to make it to be approved and accessible to, everyone. One thing that we see about clinical trials is that participation is really low in general among patients with pancreatic cancer, but definitely racial and ethnic minorities are persistently underrepresented in pancreatic cancer clinical trials. So we want to make sure that patients are aware of all of their options, including clinical trials. And so one service that we provide through PanCAN is that we actually have a comprehensive database of clinical trials that are happening in pancreatic cancer. And we can help patients locate clinical trials in their area, really based on their diagnosis, the stage and type of pancreatic cancer that they have, and their treatment history. Because if you have been on certain treatments, sometimes that makes certain clinical trials not an option for you, or others may be an option for you. And so we're able to run a really personalized search for patients to help them locate clinical trials in their area. And I guess to end, I'll just mention that it's so important for patients to participate in clinical trials, because everybody wants to see themselves represented. And if we're not testing therapies and all of the patients that are actually impacted by pancreatic cancer, then we're not really able to make progress, against the disease and develop new treatments. And so it's so important to be aware that clinical trials are an option for you, and also to seek out resources to help locate, that information. And I think all of those things will help us increase participation.
Thank you, Fatima. That was great. And it's amazing that PanCAN provides those services, and they also seem very, personalized. And a lot of folks might not know that is an offering. So I appreciate you walking through that, and also highlighting some of the value and the benefits of participating in clinical research. Did any of our other panelists anything to add? I see Pamela, you're back. Welcome. So glad to see you again.
Yes, I actually, if I can, just want to provide a more vulnerable perspective. When I was diagnosed in Florida, the doctors there told me, you need to go home and you need to get this out immediately. So go as soon as possible and get this out. So like I said, my story is a little different. At the time, I worked for Kaiser Permanente, and I was in the compliance department. So my husband, my biggest advocate, he called the CEO, and that just started a flurry of things to happen for me, which were blessings. My surgeon was the head of surgery for Kaiser, and so my story really is different. But the surgeon, he wanted me to participate in a clinical trial. But we were told to get home and get it out as soon as possible, so I declined. The interesting thing about it is when I was diagnosed, April 1st, I had the surgery April 30th, and the tumor had grown significantly between that time. So it's an interesting place to be in. Do you do the clinical trial and see what happens, or move forward with getting the tumor removed? So that's the situation I was in. It grew really significantly in 3 weeks.
Wow, thank you so much for sharing that perspective, and some of the, I don't want to say challenges, but the hard decisions that you have to make, and it's already, you have this diagnosis, and then it's like, okay, well, so what do I do? There's so many unknowns, and that perspective of, the fact that you even offered a clinical trial is awesome, because a lot of times people are not offered the option to participate, but then, you just sharing how you had to weigh that versus, having like an immediate surgery and seeing how the tumor in your case actually grew quite quickly. And we know that might not be everybody's situation, but certainly appreciate you sharing that perspective. Thank you. Dr. Weeks.
Yeah, so I would say that I think what Pamela and also Fatima have highlighted is, I think it's the importance to be seen, at least try to be seen initially by somewhere, whether it's a pancreas cancer center of excellence. I think the treatment for pancreas cancer is evolving quite rapidly, and so it's a very nuanced disease, and it's in terms of whether someone should go to surgery right away versus getting chemotherapy followed by surgery, whether they're resectable, not resectable. Like, all of these things are really nuanced decisions and thought processes that both the care team has to go through, as well as the patient. There's a question about sort of the caregivers, which I also like Pamela's story talking about her husband being her best advocate, right? And so the other thing that I think what's happening in the pancreas cancer world and cancer in general is sort of understanding the complex nature it is to be the caregiver of a patient with pancreas cancer or any cancer, right? And also trying to maintain the health of those individuals as well. And so I think all of these things are really important in terms of just how do we take care of patients. I think it's been pointed out in this conversation that education is key. And this is where I'm going to start my conversation about clinical trials. So what we know about clinical trials is that patients who are treated on a clinical trial, they have better outcomes than patients who are not treated on clinical trials. Doesn't matter what the trial is, just in general. If you say a patient's treated on a trial, they have better outcomes. And that's because they have increased access to their care team. And so, things don't fester when a patient's on a trial. Like, if you're having abdominal pain that's new, we're going to look and see why you're having abdominal pain. And maybe there's an abscess that you've developed, and that's why you're having abdominal pain, versus not investigating that until the patient's really sick and now they're in the ICU and all these things are going on. So that's, I would say, point number one about clinical trials. Point number two is that it is a way for pancreas cancer patients to get access to novel therapies, because we don't have a lot of therapies for pancreas cancer, right? So if you look at the treatments that we use for pancreas cancer, it's two basic chemotherapy regimens. One's called FOLFIRINOX, the other one is gemcitabine and Abraxane. There was a recent approval of a regimen called NALIRIFOX, which is sort of a fancy FOLFIRINOX, but at the end of the day, it's cytotoxic chemotherapy is the treatment that we have. Whereas if you look at lung cancer has a lot of biologic agents, they have immunotherapy, they have all these different therapies so that are approved drugs for the disease. So there's lots of options to treat someone with lung cancer. Breast cancer is even more so. So the only way for patients to get access to these novel therapies is part of the clinical trial. And so I think for patients of color, it's really important that that you are seen at an academic medical center where these trials are available. That's how we're going to make the inroads in patient outcomes. What also is developing is this concept of ancestry and the role of ancestry in cancer biology and potentially cancer therapy. And so ancestry versus saying self-identified race, right? So I would identify as a Black person, but my ancestry might be that I'm, of West African ancestry, right? And so if you look at patients who, by ancestry, what we see is that there may be differences in the disease based upon ancestry. So, for example, it could be that patients with pancreas cancer who are of West African ancestry, this is not true. I'm just saying this for conversation's sake, that they may have a more inflammatory tumor, in which case maybe immunotherapy may work at a higher level than it does, sort of generally speaking, in sort of pancreas cancer in general. But excuse me, we'll only be able to know that information if patients are actually participating in the trials, right? So patients who reflect that ancestry are participating in the trials. And so it is important in that I would say that most most drug approvals are based upon trials in which there isn't a lot of diversification of patients on those trials. And so they may or may not represent the disease process for patients of diverse backgrounds. And so it really is important to have diverse patients participate in trials. I think as a clinical investigator, I've been doing it all my career. We have to do a better job of educating patients in terms of what the disease process is that they have. What does the trial truly do to benefit the patient? How does the trial really impact their standard of care? Are we adding to the standard of care, or are we doing something in lieu of standard of care, right? And if we're doing something in lieu of standard of care, what do we know about that thing that we're doing, right? So are we harming patients by doing something in lieu of standard of care? So, and then I think also explaining the different phases of clinical trials. And we're kind of running down on time, but that will also be important, right? So one of the things that I'm really working on is this concept of patient education and really being able to inform the patient and their family. So, I commonly am asked to see VIPs, and I will do that. And the point I'm making here is that these individuals have access to the various highest, care, whereas other members of the society don't have access to that care. And then you also have to be able to meet patients where they are. So be able to provide them the information they need at the level in which they can receive it. And I think we have to really do a better job in medicine as a whole, but in cancer in particular, and pancreas cancer even more so, of developing educational tools that patients, not only patients, but patients' families, right? Because at the end of the day, it's the family who ultimately ends up making this decision. Right? The patient's a member of the family. But if members of the family can understand what is being discussed, then when they go home as a family and are discussing it amongst themselves, then they can also have an educated conversation about what is being considered for their loved one. And so it's really important, I think, for the medical community to do a better job in terms of providing educational materials around clinical trials and then, in this case, pancreas cancer as a whole.
Thank you, Dr. Weeks. Oh no, it looks like we lost Pamela again, but that is okay. So again, really great perspectives and lots of gems shared. I don't even think I can recap everything that you all shared just now as it relates to clinical trials. But I do believe it would be really important for us to talk about the different resources that are available, right, when it comes to understanding a pancreatic cancer diagnosis, but also clinical trial opportunities. Fatima, you mentioned a bit about what PanCAN has to offer. I know that one of our main missions from a NOWINCLUDED perspective is to educate around clinical trials as well, and also various disease states that impact our communities the most. And so if you go on the NOWINCLUDED website, we have a whole landing page that talks about clinical trials and the different phases. And we're talking to our community members and hearing their concerns, but then also learning that many community members have participated in clinical research, and we're encouraging them to share their stories with their family and friends and other folks that they know, so that people don't necessarily see it as such a scary thing. Not that it shouldn't be scary or can't be scary, but when you can see somebody and somebody who is, an aunt and uncle or a neighbor who has done this, and they're still here, they're still okay, and they had some access, and a healthcare provider who was able to explain some things to them, and they participated, and it wasn't necessarily a guinea pig situation, then you might be more likely to consider a clinical trial. So I think there are a lot of different elements that could serve to help our communities understand the importance of being part of clinical research, and also know that, again, if we're not included in the research, then how do we really know from an ancestral perspective, not just what we look like, but where we for real come from, whether those drugs work for us, especially when we know that there are certain genetic alterations that can impact how well a drug works. So really appreciate just all the perspectives there. And in our last couple of minutes, would love to hear about any of the additional resources that PanCAN has to offer. And then I see Pamela is back. Thank you again. I know that having some challenges with the stream, but that's okay. Would love to hear from a patient perspective, Pamela, in the last couple of minutes. What are the resources that you found to be most valuable to you?
Most definitely. I have to say that I leaned primarily on PanCAN. They were the source of truth for me. I was fortunate to actually develop a relationship with Pamela Acosta, the founder, and so I really utilized their services. I was kind of in the shadows, so let me say my husband utilized the services. I was more hidden. He was my block and shield. But we definitely relied on PanCAN for just about everything. So thank you, PanCAN.
That's awesome to hear. And besides the clinical trial finder, PanCAN, Fatima, are you able to discuss any other resources that are available?
Definitely. I'm happy to share. So it's wonderful because we have a really amazing and compassionate team over at PanCAN that's part of patient services. And we're really available to provide information and resources to anybody that's impacted by pancreatic cancer about any topic. So treatment options, symptom side effect management, diet and nutrition. We can connect them with specialists in pancreatic cancer. We also have a wonderful precision medicine program. I know we talked about both genetic testing and somatic biomarker testing, and we actually have a Know Your Tumor program where we provide biomarker testing and we cover the cost of that testing for patients. So that's something that we provide as well. And then we just provide free educational materials, answer questions. We can help patients prepare questions for their healthcare team and just really give them support throughout their journey. And we, like I said, we have a really compassionate team of case managers. We also have a wonderful navigation team that helps to provide more hands-on support for patients, particularly around things like clinical trials or any other barriers to care that they might be running into. We can also provide information on things like genetic testing, help individuals locate genetic counselors. So we're really here to help patients, families, anybody that's impacted by the disease throughout the entire journey with pancreatic cancer. And we're available and we're happy to help. So, yeah.
Thank you for sharing. Lots of resources, patient navigation resources, clinical trials, all the things for you and your caregiver and other community members supporting you as a patient. So that's really nice. In our last minute, any last words of wisdom or calls to action from our panelists? Let's start with Pamela, because I think she went off mute.
Yes, can I just, my story is a story of hope, and I just wanted to end with some positivity. 8 months after I finished my chemo, I did radiation chemo for 6 months. 8 months after, I became pregnant. Now, at the time, there weren't any women, there was no history of anyone with pancreatic cancer getting pregnant. So my OB said, you know what, I don't think this is gonna work. I said, you know what, I have to ride this out and see what happens. I had a healthy baby girl. Her name is Nia. She was born on 12/12/12 at 13:14 p.m. So
amazing.
All the radiation and everything.
Love it.
Yes.
Thank you for sharing. And what is meant to happen and is meant for you. And that is an amazing story of hope. And so we wish many blessings upon you and your family. Thank you for sharing, Pamela. That's great. Dr. Weeks, Fatima, any last words of wisdom or calls to action for our listeners or attendees before we log off?
Just want to say, we're here to help and support. If you have questions, if you need resources, please reach out to PanCAN. And then also there's always hope. And, make sure that if you know your body best, if something doesn't feel right, that you seek out that, support, that you go to your healthcare team and really advocate for yourself if you need to. So thank you so much.
Thank you, Fatima. Hope and advocacy for yourself.
Yeah, and I would just say, I know time is up, but I would just say that it's really important for patients who ultimately are diagnosed with pancreas cancer, whatever form of pancreas cancer it is, to be seen at a pancreas cancer center of excellence. so that you can get the optimal care. And it may not be that the care itself is delivered at that center, but I think at least being seen initially at that center to really get a full understanding of what your situation is and what the treatment options are, and if there's any clinical trials that would be relevant to your situation. I think that's really imperative. And then I would also say that self-advocacy, education in our communities is really going to be the key to battle this going forward.
Thanks, Dr. Weeks. And so what we're hearing from you is seek out treatment at those centers of excellence. And I'm sure PanCAN, with all of the resources available, are able to help patients identify where those centers of excellence are nearest to them so that they can get the most advanced treatment and options available. So thank you for highlighting that. And thank you for joining as our panelists. Thank you for all of our attendees. We appreciate you for being interactive and asking questions. Please feel free to reach out if you have any additional questions, and we will see you at our next webinar. Hope everyone has a wonderful day. Thanks. Bye.
Bye-bye.
Thank you.